My name is Anju Usman. I'm a family practice physician. I did my training at Cook County Hospital in Chicago. And just like a lot of you, we started in this idea of traditional medicine and science and wanting to help our patients. And I kind of, again, like many of you, I got a little disillusioned with treating a lot of my patients with the same drugs over and over again. And then my own children got sick. My eldest had a peanut allergy, allergies and asthma. My second one developed type 1 diabetes and mold sensitivities. And my third child has severe multiple chemical sensitivities. And I couldn't figure out how to help my own kids. And then what happened was I started working at a clinic called the Pfeiffer Treatment Center. It's in near Naperville, Illinois, outside of Chicago. And I started seeing kids with autism. And this was in 1997. So for about 20 years, I've been working with children with special needs and developmental disorders and developmental delays, mostly autism, ADD, ADHD, OCD. And guess what? A lot of these kids have problems with detoxification. A lot of these kids have gastrointestinal issues, immune issues, chronic infections. The same thing you guys see in your chronically ill patients. It's the same stuff. So what we're all talking about is the same thing. I'm just going to bring it, I'm going to talk to you guys about these same issues from my perspective of dealing with children. How many of you guys see children in your practice? So many of you guys have some experience, but there's just not a lot of people who, you know, really work closely with children, and I've done that for many years. So I just wanted to let you guys know that I own a compounding pharmacy called Pure Compounding Pharmacy in Naperville, Illinois. I'm also medical director of my clinic called True Health Medical Center. And obviously this, I'm up here to help educate you guys. I'm not here to say that this is the standard of care. This is established medical practice, as you guys understand. So I love showing this picture because this is a picture of my son when he was about 6 years old, and he did an ad for, I don't even remember, DuMont Chemical. And their whole premise on this was that now human beings should be added to our periodic table as the human element in what is happening in our environment. And so he was the human element in National Geographic. But anyway, virtually all human diseases result from the interaction of genetics and environmentally modifiable factors. Defined as infections, chemicals, physical, stressors, nutritional, behavioral factors. So even though I'm going to talk to you guys a little bit about nutrigenomics, I want you to understand, as we've all pointed out, that it's not just our genetics, it's our environment. That plays a huge role in what's happening with your patients and their genotype versus their phenotype. So the term for that is epigenetics. It's this interplay between our genes and our environment. And what I think when you talk to patients, what they don't understand when they see something as a genetic defect or a SNP or a polymorphism, they think that that's just written in stone. But people forget that genes can be turned on and they can be turned off. They can be expressed or not expressed. So like I told you, my daughter has, my eldest daughter had allergies and asthma. Well, there wasn't any asthma in my family at all. But my mom went to India in her 70s and she came back with wheezing. And the doctors diagnosed her with asthma in her 70s. Now, is there a genetic predisposition in my family for asthma? Probably. Did my mom have it for 70 years? No. But something happened to her that turned that genetic expression on in her 70s. And now she's been steroid dependent for about 7 years. I mean, it's been really severe for her too. So most of our genome, you know, is not expressed. So most of our DNA is junk DNA. There's a lot of oncogenes in there, and they're not expressed. What animal are we closest to? Whose DNA are we closest to? Fruit flies? Somebody say fruit flies? Is that you, Steve? Is that biochemistry? All those chemicals that you worked with. Pigs? Yeah, that's why Muslims don't eat pork. Is that right? I don't know, but they do say that, you know, with autoimmune conditions, you really shouldn't eat pork because of that potential cross-reaction. So our nutrition can affect our genes. And today I'm going to talk to you guys a little bit about we've mentioned a lot. David's mentioned, Steve's mentioned, Jessica's mentioned, SNPs. So when you hear the word SNPs, single nucleotide polymorphisms, what do you guys think about? I need to ask questions, otherwise you guys will all fall asleep because you just ate. So nucleotides. We'll discuss what that is. What's a polymorphism? What does that mean? Lots of differences. Lots of people have this. It's not unique. It's not a genetic disorder. So I think that's another thing that patients need to understand. When they have these SNPs, it's not a genetic disorder. It's defining their phenotype. And I explain it like, you know, your family history has cancer, your family history has heart disease. The SNPs kind of help you express those kinds of risks. It's not a genetic disorder. So, again, remember nucleotides. So remember single nucleotide polymorphism. Nucleotides are the building blocks of our RNA and our DNA. And there's different ones. So remember the purine nucleotides are the A and G, and the pyrimidine nucleotides are the C, U, and T. The adenine, guanine, cytosine, uracil, and thymine. So just to refresh your memory, because some of us learned this, you know, when we were this big. And now we're this big. When you put those three nucleotides together, what do we have? A codon, right? Remember that word? Okay, I had to review all this stuff. So then what do the codons code for? So you put three codons together, and what do you guys get? This is Khan Academy. If you were studying for your SATs, you guys would need to know this stuff. Right? What do so a codon is a code where you have three nucleotides, and you put those three nucleotides together, and you code for a protein, right? So UGA means a certain protein. So again, just to refresh your memory, these codons, so UUU would be phenylalanine, CUU, leucine. So these codons code for a different amino acid. So just to kind of refresh your memory what that meant. And remember with our transcription, we go from 5' to 3', and there's a start codon and a stop codon. You need to kind of remember this so when you get into the terminology of the SNPs, you understand what they mean, because otherwise there's a whole bunch of letters and numbers and you're like, what in the heck? Right? So again, these are the groups. So these codons group for different proteins, and the proteins have different names. And so in their abbreviations, for instance, tryptophan is, the abbreviation is W. So that, you know, that wouldn't necessarily make common sense. Some of these do make sense. So lysine is a K. So when we have these changes in these nucleotides, these polymorphisms in these nucleotides, remember the nucleotides, there's three of them and they make a codon. If you change one of those nucleotides, it's called a substitution. If you take out one of those nucleotides, it's called a deletion. Now when you substitute or you delete, then what's going to happen to your code? You're going to change the protein, right? You're going to change those little codes that I told you about. So if you substitute or delete a nucleotide, these proteins change. And when the proteins change, the enzyme those proteins are coding for changes its morphology. So if instead of an enzyme looking this way, it might look a different way in the body. So it's not going to work exactly the same way. So the terminology used with SNPs is a little confusing because they haven't really come up with really a good set of terminology. So different SNPs are named different things. So some of them are based on something called an RS number, which is a reference SNP cluster ID. And that's a unique number that indicates that unique genetic code. There's also SNPs based on their nucleotide position. So for the MTHFR mutation, the C67T, the second nucleotide of the codon is changed in a certain position, or the third nucleotide or the first nucleotide in that one. Or if you're talking about COMT, you may hear COMT V158M. That means the valine protein has been switched to a methionine protein. So that's all that means, and that's why there's a little confusion when you look at these numbers and you're like, whoa, what do they mean? So it might give you a little bit of clarity, not that it's going to help you clinically, but it could help you when you're reading papers or when you're reading reports to kind of see what's happening with these genes. So back to the lecture. So again, as we talked about, this has to do with epigenetics, that this DNA is not necessarily our destiny. And we learned this in a really famous study in 2006, where at Duke University, they're studying these agouti mice. And the agouti mice are the fat, ugly ones. I think they're kind of cute. So the agouti mice are ravenous, they're yellow, they're prone to diabetes, they just sit around and play video games all day. They don't take the garbage out when you ask them to. They don't do their dishes. They're just lazy. But the slender mice are, they have strength, they have stamina, they follow the rules, they do what they're told, and they live to old ages, and they don't have diabetes or cancer. So, Jurtel and Waterland were able to switch the agouti mice to the slender, non-toxic mice without changing the genes. And they hadn't been able to do this. Like, this is generations and generations and generations of these agouti mice. So how do they switch it? How do they switch it without changing the genes? Yeah, they change their diet. You guys are so smart. So they changed the mom's diet, and they fed the moms foods that were rich in methyl donors. So we heard about those methyl donors having those thiol groups, those sulfur groups, the onions, the garlic, B12 and folate, which help with our methylation pathway. And the mothers, even though they passed on the agouti gene, that agouti gene was not expressed. So they did not express the negative effects of that agouti gene. So when we're talking about gene expression, again, we know that the environment can affect our genes and lead to health changes. And this is from the National Institute of Health. So here's our DNA, and here's our methyl groups. And methyl groups are like paper clips on the DNA. They start and they stop transcription. So, your RNA is being transcribed, and then it hits a methyl group and it stops. So if methylation isn't working very well, we have abnormal expression of genes, and we tend to express genes we shouldn't express, like viruses and oncogenes. There are different mechanisms that affect methylation, these epigenetic mechanisms. What would you guys think besides diet would be an epigenetic mechanism that would affect our gene expression? Toxins? Yep, big one. Drugs, infections, pharmaceuticals, stress. Yes, exactly. Even the gut microbiome, now we're finding out. So there's a lot of things that you guys deal with on a daily basis that you work on to help epigenetics, that you're doing all the time. And your endpoints here are cancer, autoimmunity, mental disorders, and diabetes that you're trying to prevent or help. So the importance of methylation. So yes, we've been talking about that all morning. In addition to detoxification, it's helpful for DNA and RNA repair and synthesis. Some of the nutrients that you guys use on a regular basis are methyl rich nutrients and need methyl groups to be formed. What is the main nutrient that 75% of our methylation goes to the production of? Creatine. 75% of your methylation will go to make creatine. So again, in your under-methylated patients, what's happening with their muscle tone? What's happening with muscle wasting? What's happening with their creatine and creatinine? So it's really important that that piece, when you're working with methylation, that you have a sense of what's happening with that. Methyl groups also help to make carnitine. And we heard this morning that methylation is really important for the production of phosphatidylcholine. So probably creatine and phosphatidylcholine are the big two supplements that our methyl groups go to make. And so patients whose methylation isn't working well, they're not going to be able to make phosphatidylcholine, to make acetylcholine, to run their parasympathetic nervous system and to help their vagus nerve. And they're not going to be able to make creatine to help energy and muscle production. So methylation is also important. I'm going to tell you guys about phospholipid methylation, and also important for dopamine 4 receptors. And dopamine 4 receptors are really important for attention. So again, in our patients who are undermethylated, what's happening with their attention and focus? Just like the rest of you guys in the crowd right now. Methylation is important for T-cell methylation, as I mentioned, viral silencing. HNMT, histamine N-methyltransferase, is a methyl-dependent enzyme. It helps to clear histamine from the body, so it's important for histamine regulation, and obviously in the support of sulfation and the production of glutathione. You got all that? So here's a pretty graph, the cartoon, as we call it. And you guys know about the methylation cycle. It's etched in your brains. You guys dream about it. You eat and you sleep. You talk about it. It's your bread and butter, right? So it's methionine to homocysteine and back to methionine. It's like a clock. Methionine to homocysteine. You give off your methyl groups, which do all the fun stuff I just talked about. And on the back end, you remethylate your homocysteine. As Dr. Quigg calls it, methyl homocysteine. Back to methionine, and that is dependent on this step, which is really important. It's methionine synthase and methionine synthase reductase, and that's methyl B12 dependent. Another enzyme you guys hear all the time about from your patients, obviously, and you guys study, is MTHFR, which we'll talk about. And that's in our folate pathway, and that helps to make methylfolate. Where's that methyl group going? Right here, right? So where does it go? To B12. And that methyl group goes to B12 to make methyl B12, right? So if we have a block here, an MTR and MTRR, what's going to happen to this methyl? It's not going to go anywhere. And that's called a methyl trap or a folate trap. Those methyl groups will start to build up, and that will actually inhibit methylation because the body says, I got enough. I got enough. So if you guys read papers about a folate trap or a methyl trap, it's because this is blocked, that back end. We call it that remethylation end. So if that back end is blocked, what happens to CBS? What happens to sulfation? Either it can go downstream towards cysteine, or it might go back up towards SAW. And then you'll have that high SAH, right? So you know there's something going on here if you do one of those methylation panels and you have that weird SAM-SAW ratio. So we're going to talk about MTR, MTHFR, CBS, because I think for me, those are the main ones to kind of figure out what's happening genetically, so we can know, what might be happening phenotypically or epigenetically. The other two I like a lot to kind of try to figure out in my patients is MAOA and COMT, COMT. So we'll talk a little bit about that and a little bit about NOS. So here again, in summary, we have our methylation pathway. It interfaces with our folate pathway, and our folate pathway interfaces with our BH4 pathway, which helps convert tryptophan to serotonin and tyrosine to dopamine. And the BH4 pathway interfaces with our urea cycle or our ammonia pathway. So they're all kind of linked together. And when one gear moves, it moves the other. So when methylation moves from 12 o'clock to 6 o'clock back up to 12 o'clock, it moves this gear from tetrahydrofolate to methylfolate and back around. And then it moves this gear from BH2 back up to BH4. And then it moves NO and citrulline up to arginine. So these kind of all work together. Sometimes checking amino acid tests can help you kind of plug and chug what's going on with some of these SNPs in these pathways. Knowing what's going on with methionine is really helpful. Knowing what's going on with homocysteine. Getting a good measurement of cysteine is sometimes difficult. Knowing what's going on with glutathione. Tryptophan, tyrosine, even arginine, citrulline, and ornithine are helpful to kind of figure out what's going on and where some of the blocks might be for your patients in these pathways. Do you guys tend to do amino acid testing as well? Yeah. So because you guys may or may not be in the autism world, I don't know if you've seen this study from the Mind Institute, but because you deal with families, I think it's a really important point where mothers of children who didn't take their prenatal vitamins were more likely to have a child with autism, 2 times more higher risk to have a child with autism than the ones who didn't take their prenatal vitamins. And then the moms who had an MTHFR mutation at the 677 C to T, were 4.5 times more likely to have a child with autism who didn't take their prenatal vitamins. And then moms who had the COMT mutation, the V158M, and the H62H variants, those were 7 times more likely to have a child with autism. So again, if you guys are doing any kind of preconception planning, knowing MTHFR status, knowing COMT status, and educating the moms on the need for their prenatal vitamins. I believe that, the prenatal vitamins have folic acid in them. And if you've got an MTHFR mutation, you would think that a better choice would be methylfolate in those patients. And then in the COMT patients, I think the better choice in COMT patients would be something like folinic acid, and I'll explain my thinking behind that for you. So Dr. Deeth has done some, he's not a clinical researcher. He's a researcher that sits in a lab, and he's written a book about this thick on one gene, methionine synthase reductase and methionine synthase, where that B12 sits in the pathway. He has spent his entire life studying how that gene affects mental illness, especially things like attention. And so he wrote this paper on how the environment, and he's talking here about lead, mercury, copper, alcohol, how the environment affects genetics and this gene, MTRR, and how that combination, that epigenetic combination, messes up our redox status and leads to oxidative stress and leads to desynchronization of neural networks. And not just autism, but this was the model. Here's another paper by Dr. Deeth, again, stating how copper +2, lead +2, mercury +2, and aluminum +3 inhibit that enzyme methionine synthase. That enzyme is very important for dopamine methylation, phospholipid methylation, and attention, but it's also important for insulin-like growth factors and various growth factors in the body. So interrupting that enzyme really affects neurology. So here's an example of SNP testing, and I put this example up because I want you guys to know the variations. You can't just use the word MTHFR. You can't just say, I have an MTHFR SNP. You have to be specific about what that SNP is, because it's meaningless in the research. So again, when you're talking about MTHFR, the big one that's studied is the 677. The C677T. There is a secondary one called the 1298C. It's not as detrimental as the 677. So a plus in a 1298C isn't as huge of an issue clinically. The same thing when you're talking about COMT. The COMT V158M and the H62H are the ones that downregulate that gene. The 61 might upregulate the gene. So again, the genes can be upregulated or downregulated depending on which polymorphism you're looking at. So these are the main players. So again, if we're talking about methionine synthase and methionine synthase reductase, these are the kind of the biggies. So when you get those reports, you'll get a whole bunch of these, and you need to focus on the important ones. So again, when you get the reports, it'll look something like that. And you have to kind of tease out which ones you really want to focus on, which ones have the science, which ones have the studies. And so that previous slide are the ones that I think are, the important ones in terms of our methylation and our detoxification pathways. You guys still with me here? Yeah. Okay. So again, when you're looking for CBS, we're looking for the A360A and the 699T. And so even though there's a CBS++ here, I'm not going to worry about that. There's no research behind that one. All right, and so again, you'll get glutathione genes, methionine, methyl tetrahydrofolate reductase genes, MTRR in your reports. NOS. So, some people say, again, you can't change your genetics. Well, you can't change your genetics, but you can change how your genetics might be expressed or dealt with. So again, we're talking about these genes that code for enzymes. The enzymes are weak or not working the right way. So that process isn't working the right way. Well, all these enzymes have cofactors, right? They have cofactors that help, the enzyme potential, or help the enzyme activation. And so Dr. Bruce Ames, who's really famous in all his research on nutrition, did this study on polymorphisms and found that if you gave the cofactors for these various polymorphisms, you were able to make that enzyme work better. So it's not like the enzyme is dead. It's not a zero. It's just not working efficiently and as effectively as it would have. But by giving the nutrient or the vitamin or mineral cofactors, you're able to kind of overcome these polymorphisms. So he has studied this, and we do have evidence for this. And the ones that he studied, he did study MTHFR mutations in his particular research. He felt that for the MTHFR mutations, a cofactor of B2 helped with upregulating that gene, FAD. So let's go back to methionine synthase. That's the gene that Dr. Dick Deeth studies. That's the gene that's sitting at the crux between folate chemistry and methylation. That's the gene that's sitting where redox is occurring. So remember, that's homocysteine back to methionine, and it's involved in dopamine methylation, which is involved in attention and focus. It's inhibited by copper, aluminum, lead, and mercury. It's dependent on the methylation of vitamin B12. So Dr. Newbrander, who's in our audience today, he is the guru of methylcobalamin and the use of methylcobalamin in my world of children with autism. And when he brought this out in 2004 and worked with Jill James on her research on this, it was just groundbreaking for kids who had issues with language, processing, comprehension, attention. It is an extremely valuable tool. And again, I don't know how many of you guys use methylcobalamin injections in your practice, but because it's at the crux of a lot of these problems, it can be very, very helpful for many patients. There's no good test to see if you're B12 deficient. We go to a lot of think tanks with Dr. Deeth, and what he's finding is when you turn 50, it's like the bottom drops. He says when you turn 50, you develop a cerebral B12 deficiency. Now, why do you think that might happen? Why would it happen that when we turn 50, our brain would become low in B12? Is there a good reason for that? I still want my attention. I still want my focus. I still want to make my serotonin and dopamine through that BH4 pathway. He says because when we get older, we are more oxidized. And when we have oxidative stress, what happens? Our body needs to make more glutathione. So our pathway needs to go towards glutathione. It goes away from methionine synthase reductase and methionine synthase. And so our bodies don't need the B12. It's pushing it down. So I think the research is going to come out, but there is this this propensity towards B12, cerebral B12 deficiency in elderly people. But you can't measure that on a blood test because it's cerebral. Unless you do CSF testing, you're not going to know. So the only way to kind of treat this issue is to trial it. And so Dr. Newbrander's protocol, and I feel kind of weird saying it here when he's sitting right there, but Dr. Newbrander's protocol hasn't changed, right? Close enough. So we usually give it subcutaneously at 75 micrograms per kilogram every third day is kind of the basis for trialing that. And I usually trial it for 2 to 3 months to see how the patients do with that. 75 micrograms per kilogram. It's on your right. Sub-Q in the upper outer thigh. Dr. Newbrander has videos. Right? Say it again? Don't say it. Yeah, if you go to his website, he has some videos, and this is his protocol that I've been using since forever. There are other forms of B12. Obviously, the one that everybody talks about when you use the word generic B12 is cyanocobalamin. There's also hydroxycobalamin and adenosylcobalamin. When would you guys might consider using something like adenosylcobalamin? So if MMA is high or if they have a big MMA SNPs on testing, then you might want to think about using adenosyl B12. It's a marker. Methylmalonic acid, high levels of that is a marker for adenosyl B12 deficiency. There's also a form of glutathione that Dr. Deeth talks about called glutathione B12, and it's an intermediary, and we don't have that to give you in a form yet, but maybe some people can work on that. Smart people. I'm just a doctor. So the big gene that everybody talks about, a lot of the families come to me and says, I want to test for the autism gene. Well, there is no autism gene, but this is one of the genes that they have studied. Like I said, the Mind Institute studied it, and many other groups have studied this in terms of being a propensity towards autism. Again, this is the gene that converts methylene tetrahydrofolate to methyl tetrahydrofolate. If the enzyme is weak, methyl groups are trapped and unable to provide methyl to B12 to move that back end of the methylation cycle. This enzyme is B3 dependent and can lead to elevated homocysteine. Do you guys have a cutoff for homocysteine that you like to see? I mean, we talked about normal ranges, and we talked about ideal ranges. Is there a good range that you guys like to see for homocysteine? 11. I've heard 6 and 7 kind of thrown out there. So my patient population doesn't have a lot of cardiac risk factors, but I'm still looking for a homocysteine of less than 7. So this gene is associated with coagulation defects, poor detoxification of nitrous oxide. So patients with this mutation, you need to also educate them on laughing gas, especially for little children where they tend to kind of overuse it potentially. There are studies to show that anesthetics, multiple anesthetics, in young children, given very young, can lead to developmental delays. So we all have to be careful with the use of these things in the young and the old, and again, the susceptible patients, and especially with patients with this MTHFR 677 mutation. These moms also have frequent miscarriages and should not use birth control pills. I think you guys know a lot about that one. You can use methylfolate as an adjunctive therapy for SSRI-resistant major depression. I don't think they did the study without the SSRI. So that's the kind of the conundrum that we have is, could the methylfolate work by itself without the SSRI? I say yes, to upregulate serotonin. So when we're talking about folic acid, you guys know the differences of the different kinds of folates that are out there. Again, there's just the regular folate, which is, it needs to be reduced. So folic acid needs to be reduced to dihydrofolate. That needs to be reduced again to tetrahydrofolate. Again, if you have a patient with a lot of oxidative stress, are they going to be able to do those reduction processes? So folic acid is not ideal. There is folinic, it's non-methylated. So again, if we have an overabundance of methyl groups, we're not moving them. Initially, that might be helpful. It can also be used for something called cerebral folate deficiency, or CFD. The prescription version of this is called leucovorin. And for CFD, the dosing is 0.5 to 2 milligrams per kilogram per day in 2 to 3 divided doses. Methylfolate is also available as a prescription called Deplin, and if it has NAC in it, it's called Serafolin. So this is a case study of a 6-year-old with psychomotor regression, developmental delays, mental retardation, and seizures and autism features. She was found to have a low cerebral folate level, CSF level of methyl tetrahydrofolate. She was treated with leucovorin at the high doses, and her symptoms and her abnormalities improved, and her motor skills improved. So Dr. Quadros did a study in 25 low-functioning autistic kids. He found that 23 of those 25 kids had low cerebral folate deficiencies. When he treated them with high-dose folinic acid, their autism improved and their neurological deficits improved. So many of our patients have what we call cerebral folate deficiencies. Many of our patients, especially over 50, potentially have cerebral B12 deficiencies. We don't know if they have these things. So again, if you have a very developmentally delayed patient, it's worth trialing high-dose leucovorin and the methylcobalamin. Now, you can do a test to check for blocking and binding folate receptor antibodies. If you have folate antibodies to the receptor, you cannot pump folate into your CSF. So that's a kind of an indirect measure of seeing if folate is getting into the CSF. If you have blocking antibodies, folate blocking antibodies, and folate binding antibodies, then you'll have trouble getting folate into the CSF. Dairy also increases those blocking and binding antibodies. So patients with these issues, we often recommend a dairy-free diet. The COMT enzyme that I mentioned before, let's see if we can, I'll try to kind of refresh your memory about where that sits. Hang on. So COMT is, sits right here, catecholamine methyltransferase. It's another one of those MT enzymes, methyltransferases. They're methyl dependent. They're SAMe dependent. That's the main methyl group. And so when this is not functioning, we have an overabundance of dopamine, norepinephrine, and epinephrine because COMT helps to detoxify these catecholamines. So it's a catecholamine O methyltransferase. So if we have a defect in these, this particular enzyme, and the two that I mentioned again are these two, its cofactor is magnesium and B3. If this enzyme is weak, again, you're not using up your SAMe very well, and these methyl groups might accumulate. Some people have heard the terms over-methylation and under-methylation. Well, in this case, it's not really clear as over-methylation. The body isn't over-methylating. What it has is an overabundance of methyl groups that it's not utilizing. It's still under-methylating. So these patients are still not methylating appropriately, but giving them more methyl donors initially doesn't really help the process open up. So in both cases of COMT++ and COMT-, in COMT-, the patients have undermethylation because of the oxidative stress and their issues, and therefore the COMT gene will use up a lot of those methyl groups rapidly, and then SAMe can become even more depleted. So in my experience, these COMT patients have a lot of hyperactivity because of that high norepinephrine. They have a lot of anxiety. Some of them might have rage issues as well. The COMT gene also helps to detoxify estrogen, as we heard before. And it's also important in the detoxification of amines, the different amines that we heard that are toxic, as well as phenols and estrogen. Now, there are two substances that inhibit this enzyme even further, and in my COMT++ patients, I don't think it's a good idea to use quercetin and curcumin. So quercetin and curcumin will further inhibit COMT. So be very careful with those supplements in that patient population. MAOA, considered the warrior gene, this one here, MAOAR 297R, the gene, is associated with aggression. And MAOA, as you see on the on our little slide, helps to detoxify not only serotonin, but it's really important for dopamine detoxification as well, and histamine detoxification. So amines, catecholamine oxidase, it gets rid of amines. So a lot of our perfumes, our chemicals are amine related. So these patients have a lot of sensitivities to amines. Have you ever heard of the fail-safe diet? The fail-safe diet is that low amine diet, the low histamine diet. These patients don't do well on vinegar or fermented foods because they're high in amines and these various phenolics. So I'm actually doing a study on patients with MAOA using a homeopathic substance called Respin A, and it's supposed to help balance MAOA and MAOB activity. So when MAOA activity is low, MAOB activity gets upregulated. And when you upregulate MAOB activity, you create more oxidation and you deplete glutathione even further. So all of these are very related. There's not a whole lot of things in the literature that can upregulate MAOA and COMT. Progesterone can do it. And progesterone also has agonistic effect on GABA receptors. And then serotonin turnover can help upregulate MAOA and COMT. So low-dose SSRIs or low-dose 5-HTP can also help modulate MAOA. I know this is a tough lecture, especially after lunch. I feel like I'm losing you guys. So we had a question earlier on about CBS. There's a lot of controversy about like what this actually means. I mean, we're talking here about giving patients all this sulfur with glutathione and all these thiols. And, you know, there is a subset of our patients who have these sulfur-reducing bacteria in the gut that if we give them a lot of sulfur and we don't address that and we don't treat their SiBO and they don't treat their dysbiosis, their GI system will just blow up on us. So we have to be cognizant of, you know, the different variations. But CBS, when we're looking at these SNPs, this is considered an upregulation, not a downregulation. So in this case, the enzyme works really rapidly. Now, CBS sits on chromosome 21. So any of you guys see Down syndrome patients? So Down syndrome patients have naturally an upregulated CBS because they have an extra gene working here. So they make more CBS. And so their CBS gene works very rapidly. So again, this enzyme is upregulated. It helps convert homocysteine through a B6-dependent mechanism down towards cystathione and cysteine. Now, CBS can be upregulated by methylation, oxidative stress, and inflammation. So again, that would make sense. Vitamin D can also upregulate CBS, and there are certain things that downregulate CBS. Dr. Deeth said that CBS activity in Down syndrome limits methylation by removing homocysteine from the methionine cycle. So I'm going to kind of show you what that means. If we have upregulated CBS, our homocysteine is moved away from that folate pathway. It's moved away from methionine synthase and it's moving towards glutathione to help regulate the redox status. So again, things that will upregulate this pathway, SAMe, vitamin D, oxidative stress, and inflammation, will then inhibit methionine synthase. So again, that in an acute state, that is really helpful. Our bodies need to do that for acute inflammation, acute oxidative stress. But the problem comes in is when these issues become chronic. When we end up with chronic oxidation, we come up with chronic inflammation, then our system is taken away from that folate pathway and our neurotransmitters aren't made efficiently because we're trying to, again, upregulate glutathione this whole time and help calm down oxidative stress. All right, so again, during oxidative stress, multiple mechanisms are at play, and there's a lot of play going on with our sulfur resources, and those sulfur resources are going towards glutathione, but that lowers methionine synthase activity, and when methionine synthase activity is low, we can't make the tetrahydrofolate, and we can't make our neurotransmitters efficiently, and we can't methylate dopamine. And so it moves the system away from attention. So that's why people with oxidative stress have really poor attention. So we talked about a little bit about phospholipid methylation and how you need methyl groups. You need SAMe to convert phosphatidylethanolamine in 3 methyl-dependent steps to make phosphatidylcholine. So that's a really methyl-consuming process. So if you give a patient phosphatidylethanolamine, you're going to use up a lot of methyl groups. So if you need to use up methyl groups, if they've got COMT++, or if they've got a folate trap, then that might be helpful. But if you are deficient in that, then you don't want to do something like that. So I'm going to skip these oxidative stress slides. So again, just to bring the point home, our methylation pathway is our methylation potential, and our SAM-SAW ratio is our methylation potential. The transsulfuration pathway, cysteine to glutathione, is our antioxidant potential, and that's the reduced glutathione to the oxidized glutathione ratio. And then again, our folate pathway and our methionine synthase kind of sit here, and there's a balance between all this that is sometimes hard to regain, especially in a chronically ill patient. In Jill James' study in 2004, which Dr. Newbrander helped with, she gave patients, so what we found in children with autism and patients with oxidative stress is that they have low methionine, high SAH, low SAM, high adenosine, low cysteine, low reduced glutathione, and very high oxidized glutathione. And when she gave folinic acid, methyl B12, and TMG, trimethylglycine, she was able to normalize those factors in the patient population she saw. There are other SNPs that are associated with oxidative stress and redox. They're not talked about as much, but again, if you do some of these testing, these might be important to you. NOS, SOD, glutathione sulfur transferase. In particular, these two genes, the GSTM1 null and the GSTP1 variant here. And the glutathione peroxidase gene that we've talked about, that is selenium dependent. So again, with NOS, there's 3 different isoforms. Nitric oxide is cardioprotective. Low nitric oxide is associated with hypertension, diabetes, and Alzheimer's. It helps to modulate neurotransmitters and involved in the urea cycle. This NO with citrulline helps to make arginine. SOD is very important. SOD1 is in the cytoplasma. SOD2 is mitochondria. SOD3 is extracellular. SOD1 and SOD3 are copper and zinc, contain copper and zinc, where SOD2 contains manganese. They have very powerful anti-inflammatory effects, and they help with oxidative damage. So again, these are some examples of NOS. Now, I don't know which SNPs are the most important, so I kind of look at groupings of things. So when I look at NOS, I look at the whole group. Same with SOD. Here's SOD2++, SOD2++, PON1, peroxidase. GSTM1, null, and GSTP1, isoleucine, valine polymorphism are, in this particular meta-analysis, they combined many, many studies and found that these 2 genes were associated with Alzheimer's. And again, we believe because of the oxidative risk involved. The glutathione peroxidase, this was a really interesting study, I thought. They took obese women with this particular polymorphism, and they looked at their selenium status and oxidative stress markers. And when they gave them 1 Brazil nut a day, just 1, they improved their oxidation status, and regardless of whether they had the SNP or not. So it was protective for these obese women. So it was just 1 Brazil nut with that glutathione peroxidase polymorphism that helped those endpoints. So hang on. All right, so just let go of everything I just said. Yes, I told the gentleman in the back his brain was going to explode when I gave this lecture. So, again, I just have a few more minutes because we started a few minutes late, and Dr. Schrader said I could go a little longer. Again, back to our little pathway. And because we're talking about detoxification, I wanted to also, go beyond methylation and talk a little bit about sulfation here. So remember, methionine feeds homocysteine, which feeds cysteine, and cysteine helps not only with the production of glutathione, it's the main amino acid for the production of metallothionein. It helps make the sulfur amino acid taurine, which taurocolic acid is important for also detoxification. Cysteine also helps to make ALA, which we know is very important antioxidant for the brain. Also potential metal chelator, and cysteine helps to make sulfate. So let's not forget about how important sulfate is. This is a study on sulfation, methylation, glutathione, and oxidative stress markers in children with autism, and basically they were all off compared to neurotypical children. So sulfation is extremely important for the detoxification of xenobiotics. It helps to make an enzyme called PST, or phenyl sulfur transferase, which helps to clear amines and phenols. I think of sulfate as Scotch tape. It sticks cells together. So if you don't have enough sulfate, you have leaky cells, even leaky gut, leaky lungs, leaky blood-brain barrier. So sulfate, you need sulfate for integrity. Tyrosine sulfation helps to make gastrin and cholecystokinin and DHEA, so it's important for that. And it's also important in thyroid and dopamine metabolism and cholesterol metabolism. The SNPs we're talking about here are SUOX SNPs and a sulfur transferase SNPs called SULT. We talked earlier about phase 1 liver detoxification, and remember with phase 1 the SNPs are going to say CYP something or the other. CYP 1A1, CYP 1B1, CYP 2D6, 2C19, 2E1, and 3, 4A are kind of the biggies that have been researched a little bit. Again, the numbers or the letters aren't there yet. So we don't have enough research to say, okay, this is the one for this estrogen metabolism. But in general, A1, B1, A2 help with steroid hormones and cholesterol metabolism. Various ones help clear xenobiotics and various drugs. A really good website to go to is... Sorry, Darren. Indiana University School of Medicine. I went to school there, so I have to put in a plug. But this is a really great table, the Flockhart table, and they can send you out little cards. And the Flockhart table tells you what are inhibitors of those various cytochromes and what are inducers of the various cytochromes. So, for instance, if my patient has a lot of SNPs and CYP2D6, for instance, and I go to the chart. Well, Benadryl goes through CYP2D6, cimetidine goes through CYP2D6, chlorpheniramine goes through that pathway. Prozac is a strong inhibitor of that pathway. So again, if I have a patient who has multiple CYP2D6 SNPs, and then they're on Prozac, and I give them Benadryl, that phase 1 detoxification enzyme is going to be pretty weak. So it kind of guides you. Now there are some tests out there, like GeneSight and various ones that'll do all the work for you. So basically you do the test and they'll run the cytochromes. They'll give you the list of the drugs. You can even tell them what drugs the patient is on. They'll say whether it's a good idea or a bad idea. And then they'll even make recommendations for various seizure medications and various things like that run through these enzymes. But if you just go online and you Google the Flockhart table in Indiana University, you'll get the list of these things. And I just keep that with me in my consults so I can kind of look at it when I'm prescribing meds. I think it's really valuable. So again, to support that liver detoxification for phase 1, the B vitamins, lots of antioxidants, eating the rainbow, 12 servings of fruits. Is that what we're supposed to eat a day? I think I'd be going to the bathroom a whole lot if I did that. Supporting methylation pathways is just not as simple as giving folate and B12 and DMG and TMG in a supplement. Kind of gearing it and individualizing it. Working on sulfation. Sulfation is dependent on B1, biotin, molybdenum, B6 if we have CBS not working very well. Working on glycine, taurine, obviously glutathione, and glucuronidation if needed. So it's a lot of work that needs to be done to get those intracellular toxins moving to the extracellular space so our detoxification agents can work, that we're going to learn about from Dr. Schrader. Another really good supplement to consider trying in somebody you've worked on their dysbiosis and they don't have the sulfur-reducing bacteria is NAC. They did a study in children with autism at Stanford, Dr. Hardin study. He gave 900 milligrams 3 times a day to children with autism, and it improved all 3 areas of autism: social, behavior, and language. In specifically OCD, I've had some really good success with patients with trichotillomania. I've had about 3 or 4 of those patients in my practice, and the high-dose NAC really, really helps prevent them from pulling their hair or eyebrows. Interesting enough, it can solve pathological gambling potentially. So if any of you guys have that issue, run out and get some NAC. And obviously the mucomist is used in acetamin overdose. So I hope some of this kind of helped you guys a little bit clinically and understanding some of the nuances of some of these SNPs. And don't be afraid to kind of use them in your clinical practice.